Hi, I'm Dr. Iris Amelia. What if I told you that Botox, yes, the same injection people use for wrinkles, might help men who've tried everything for erectile dysfunction and still aren't getting results? I know that sounds surprising, but over the last few years, new research has unlocked some eye-opening data that challenges what we thought we knew about treating the tougher cases of ED. Before anything else, let me be crystal clear. This is not FDA approved for ED, and it's not in standard clinical guidelines yet. It's experimental. But the science is interesting enough that you should know what's happening and who might potentially benefit. So, how could Botox possibly help? Quick anatomy and physiology. Think point and shoot. Point is the erection, controlled mainly by your parasympathetic nervous system. Shoot is ejaculation, driven by the sympathetic system. Botox works by blocking sympathetic neurotransmission. It reduces the release of norepinephrine, the chemical that keeps smooth muscle tense. In practical terms, an overactive sympathetic state, stress, chronic disease, high blood pressure, diabetes, makes it hard for penile smooth muscle to relax, and if that smooth muscle won't relax, blood can't flow in and hold to create a firm erection. Botox essentially tells that overactive stress response to calm down, so the penile smooth muscle relaxes, blood flows in more readily, and rigidity can improve. You can also think of Botox as a mild paralytic for targeted muscles, the same idea behind facial Botox, but applied to the smooth muscle within the erectile tissue. What does the evidence show? The first randomized controlled trials were small but thoughtfully designed. One early RCT with 24 men, all of them had failed oral meds and other options, compared Botox injections into erectile tissue to saline. At 4 weeks, the Botox group showed meaningful gains in erection hardness and overall erectile function. Some men who had been considering penile implants got firmer erections again. Bigger trials followed. A study of 176 men compared 50 units versus 100 units and found both doses helped at 3 months. But by 6 months, the 50-unit group began drifting back toward baseline, while the 100-unit group maintained better results. That suggests dose matters, and higher doses may last longer, similar to other Botox uses where effects wear off over time. A well-designed, double-blind, placebo-controlled trial published in 2020 enrolled 70 men who didn't respond to pills. They used validated measures, erectile hardness, blood flow on ultrasound, sexual function questionnaires, and the Botox group improved significantly versus placebo. At 2 weeks, the treated men had an average 5-point rise on validated sexual health scores, and 53% could achieve penetration-firm erections versus 3% in placebo. Improvements lasted about 3 months in that report. Not every study is uniformly positive. A 2025 multi-center trial didn't show an overall benefit when Botox was added to Viagra for all comers, but when they analyzed men who were fully compliant with the oral meds, those patients did get extra benefit from Botox. In other words, synergy between medications and Botox may matter. Real-world data are also informative. A 2023 registry of 216 men who received Botox for ED reported that about 43% returned for a second injection, suggesting many found it worth repeating. And the average repeat interval was roughly 9 months. In my own practice, I've seen a high return rate when patients find benefit. Many ask for second and third injections. Response rates vary by baseline severity. Mild ED patients show the highest response, about 90% in some series, moderate ED roughly 55%, and severe ED around 33%. But combining Botox with oral meds or intracarbonosal therapy can raise response rates in severe cases closer to 50 to 60%. Men with neurologic causes, post-prostatectomy denervation, or spinal cord injury generally don't respond well. This approach seems best for vascular and smooth muscle predominant ED. What about safety? Across the published studies, Botox's safety profile has been reassuring. The most common complaint is transient pain at injection, and many clinicians use topical anesthesia. We usually place a constriction band during injection and for about 20 minutes after as a safety precaution to limit systemic spread. Serious adverse events are rare. There has been one reported priapism case across the available literature. Priapism, a painful erection lasting more than 4 hours, is an emergency and must be treated promptly to avoid permanent damage. That risk is low, but it's one reason we counsel men carefully and make sure they understand what to do if an erection persists. No consistent systemic complications have been reported, and no long-term safety signals have emerged so far, but follow-up windows in studies are limited. Limitations of the data. Most trials are small to moderate in size, follow-up is typically months rather than years, and methods vary. Dose, injection pattern, and patient selection aren't standardized. We need larger, longer randomized trials to nail down optimal dosing, best injection technique, who the ideal candidates are, and long-term outcomes. Botox's effect is not permanent. Repeat injections every 6 to 9 months are typical for those who respond. Who might be a candidate? Based on current literature and clinical experience, likely candidates are men with vascular predominant ED who have failed oral PDE5 inhibitors and are seeking alternatives short of prosthesis. It's not generally helpful for men whose ED is primarily neurologic, post-radical prostatectomy with major nerve injury or spinal cord injury. Offer Botox only after a thorough evaluation and ideally within a clinical trial, if one is available. Remember, this is experimental, not guideline endorsed, and insurance typically does not cover it. A few practical pearls. Injection technique varies. Most clinicians perform a set of targeted intracarbonosal injections under local anesthesia. Pain is short-lived, and the constriction band is used out of caution. Expect the effect window to appear within days to weeks, peak at a few months, and decline over months. Repeat treatments are commonly requested at about 9 months in many series. In some reports, men also noted a change in flaccid length because relaxed smooth muscle makes the flaccid penis hang lower. Not a permanent length change, but a temporary effect tied to muscle relaxation. Bottom line, Botox for ED is promising and biologically plausible. Response rates in reported series vary widely, roughly 40 to 77%, depending on population and severity. And combination therapy appears to work better than Botox alone for men already using oral meds. The safety profile looks acceptable in the short term, but long-term data are limited. It's not FDA approved for ED, and it remains experimental in many places, so discuss it candidly with a urologist who understands the data, ideally within a research setting. If you're considering this because you've exhausted first-line options and you'd like to avoid surgical implantation, it may be worth a conversation with a specialist, especially if you can access a clinical trial. Trials are the best way to get structured care, standardized follow-up, and contribute to the science that will tell us whether this belongs in standard practice. And one small favor, many people watch but don't subscribe. If this video helped you, hit subscribe. It's free and it tells YouTube you want to see more of this evidence-based content. As always, take care of yourself. You are worth it.